Well, presentation, we don't.
Do I know when to start talking, or should I just?
Okay, wasn't turning in a time now.
Hello, everybody. Thank you on this webinar about how to use pressure ulcer risk assessment tools in care planning. Started on the content. I'd like to do a little bit about me. I am a board-certified wound and ostomy nurse who for 25 years has been the clinical editor for the journal Advances in Skin and Wound Care. I am the Vice President of the World Council of Enterostomal Therapists, or WCET, a fee member at Excelsior College School of Nursing in New York, and author of over 100 peer-reviewed journal articles and 2 wound care books. Yes, I have been the president of the National Pressure Ulcer Advisory Panel, or NPUAP, and I have consulted to the Centers for Medicare and Medicaid Services, CMS, on revision for guidance for sales for FTAG 314 on pressure ulcers and skin conditions for long-term care, long-term acute care hospitals, or LTACs, and rehabilitation facilities, patient assessment instrument, or IRF. Today, I am here to talk to you about pressure ulcer risk assessment tools and how to use these pressure ulcer risk assessment tools in care planning. Recall, these topics were introduced in your one-day training. Today, revisit them in more depth. Write down your questions. Your specialist will follow up with you after this webinar to address them. See here, this pressure ulcer we want to avoid, and this is why we're going to be looking at risk assessment and prevention. Pressure risk assessment should be a comprehensive process that has several steps. There are aspects of pressure ulcer risk assessment that I will review with you. This includes attributes of risk factor assessment, risk factor assessment, and basis for risk factor assessment. Let's begin with describing attributes of risk factor assessment. This includes many components, including the results of a comprehensive skin examination, which Karen Zukowski described in great detail in another webinar in the series. Risk factor assessment is multifaceted. Besides a comprehensive skin examination, it includes, at a minimum, the patient's history, medication profile, comorbidities, and other relevant diseases. It is ongoing. You have to keep performing the same task over and over and over again. And you have repetition. That leaves us the potential problem making sure that staff is doing it correctly as do it over and over and over again. And risk assessment is standardized. It's just a way to review the factors that put persons at risk for a pressure ulcer. It's like you need a map, a guide, so you know where you're going to look at pressure ulcer risk assessment. Identifying patients at risk for developing pressure ulcers takes skill. One way to help direct this process is by using a standardized risk assessment tool to guide clinical decision-making, especially for people at mild to moderate risk. Clinicians, we tend to be really good at identifying people that are at very high risk of pressure ulcers or at no risk for pressure ulcers. It's that middle group that tends to be problematic for us. Pressure ulcer prevention interventions can be resource intensive. They cost money, and time. Therefore, select targeting of preventative interventions helps to use those resources on patients at greatest risk of pressure ulcer and benefit most, and avoid using costly and sometimes painful interventions on patients that just don't need them. Therefore, preventative pressure ulcer care planning can just focus on the specifics for the individualized patient. Communication between healthcare workers and care settings is important, especially now that patients move from hospital to home, or hospital to long-term care back to the hospital. People are moving through the healthcare system rather quickly and frequently. Having common language is vital so we all know what the individual's pressure ulcer risk. For example, does low risk mean no risk for a pressure ulcer? Or does it mean that the person at risk for a pressure ulcer, they are at risk, but the low risk of developing a pressure ulcer? You can see how understanding what low risk means can be complicated. All givers need to know the person's pressure ulcer risk. This information should be included in patient handoff reports, for example, so that everybody knows what the person's pressure ulcer risk is. Or that the purpose of risk assessment is to find patients who are more likely to develop pressure ulcers. Well, unfortunately, we don't know exactly the combination of factors that result in the development of a pressure ulcer. We're learning more about the etiology of pressure ulcers. We believe that it is some interplay of internal and external factors that occur in an individual in a certain set of circumstances to result in a pressure ulcer. The 2014 NPUAP, EPUAP, PPPIA clinical guide on pressure ulcers, there is an etiology section. And talk about some of the dynamic processes result in a pressure ulcer. Obviously pressure, that's why they're called pressure ulcers. Forces, which result in tissue deformation, and the emerging concept of microclimate. Do a risk assessment. Most pressure ulcer clinical guidelines recommend doing a risk assessment on admission to the facility. What has been unclear in the past is exactly what time frame this means. The 2014 NPUAP, EPUAP, PPPIA guideline provides guidance to exactly what this should be. They say as soon as possible, but maximum of 8 hours after admission. Remember that risk assessment includes doing a comprehensive skin assessment as part of the pressure ulcer risk assessment using a standardized tool. 8 hours may have to be changed if you're not in a hospital setting. It may be the first time that the clinician or the RN actually sees the patient. Their guidance specifically now says 8 hours after admission. Frequency that pressure ulcer reassessment for risk should be done will be based on the patient's acuity. So, for the patient, the more frequent the pressure ulcer risk assessment should be performed. And finally, whenever a significant change occurs in the patient's condition. What significant mean? For example, if a patient goes to the operating room, that's significant. And the risk assessment should be done after the patient has been discharged from the operating room, is in the PA unit, and then is sent to the other unit. Also, anytime a patient is transferred from one unit to another, particularly the patient's acuity increases or decreases, it's to do a pressure ulcer risk assessment. A little bit about mentioning that we have pressure ulcer risk assessment tools. And here you see some of the standardized tools that are used in the United States for the adult population. There are tools for pediatrics, and if your hospital uses pediatrics, you need to focus in on those tools. These are adult tools. The Norton scale has 5 factors, and you can find this scale in the resource section of the AHRQ toolkit on page 36, and it is tool number 3E. Braden scale is on in the resource section of the AHRQ toolkit. It's number 3E, and the information begins on page 134. It's not what tool you use, but how you use it. So you use it correctly, and you have to use it consistently. That is, you need to use the scales so you make sure that staff understand how to use them and that the entire scale is provided for staff. It's not something that they memorize. They need to take the scale in front of them to use it. Also, don't use it alone, but in conjunction with a comprehensive assessment of other risk factors that the patient may have. So let's spend some time talking a little bit more about the Braden scale in some more detail, since it's one of the scales that's most frequently used in the United States. Developed in the 1980s by Dr. Nancy Brooks and Dr. Barbara Braden, two nurses. They developed the Braden scale with the following 6 factors, as you see listed here: sensory/perception, moisture, activity, mobility, nutrition, and friction shear. On the next slide, you're going to see those 6 factors with the different descriptors that are listed so that the clinician can quantify the patient's risk, I see, for each of the 6 factors. And once again, remember, you have this scale on page 134 in the resource section of the AHRQ toolkit. Attention to the first factor, sensory perception, because people sometimes misunderstand this particular factor. So what is always understood is that you really are assessing 2 different parameters: the ability of the individual to respond or not respond to verbal commands, or see that word "or," ability to feel pain. It's 2 things. However, you only put 1 score recorded patient. So whichever is the lowest is the one that you will be recording for sensory perception on the Braden scale. How do you score these risk factors? Well, are scored from 1 to 4. So sensory perception, moisture, activity, and nutrition are all scored from 1 to 4, where 1 is the lowest level of functioning and 4 is the highest level of functioning. Last subscale, which is friction shear, only has 3 options. So you only have 1, 2, or 3. Remember, the number 1 is the lowest score. Now, not all people fall neatly into one of these numerical categories. So if you do an assessment of a patient, if you find that, I'm not sure, are they a 1 or a 2, are they a 2 or a 3, or are they a 3 or a 4, it's better to choose the lowest numerical score. Now, as nurses, we always want to give our patients the benefit of the doubt. We always want them to have higher numbers. All of us are getting higher grades, so we like higher numbers. But here, remember that it is better to err on the side of doing preventative interventions for somebody rather than choosing not to do that. When you use these standardized tools, make sure that you actually do assess the patient, and also make sure that people are recording it after they actually do the assessment. For sub-score, therefore, a number will be recorded. You got to document it. Then the subscale scores are added to obtain a total score that can range from a low of 6 to a high of 23. Make that you add up the numbers correctly. I can tell you in legal cases, we'll check that. So you need to make sure that we're adding the numbers correctly. We have to make sure that what we record makes sense. What do I mean by that? Well, it's about what the patient's status is now. Do they reflect what's going on with the patient? So, for example, if a patient is unable to walk, you don't choose number 4, which means that the patient walks frequently for activity. And again, sometimes people just don't really do the assessment. They just write down numbers. You need to go in and look at the patient to determine what their status is now. Are they eating now? Are they walking now? Etc. So lower numerical scores on the Braden scale indicate higher level of risk for pressure ulcer development. Research has determined that a score of 18 or less indicates that an individual is at risk for developing pressure ulcer. A subscale score indicates the patient is at risk from that particular factor, and interventions that address that deficit need to be included in the plan of care. But do not rely only on the total overall Braden scale score. All low subscale scores must be taken into account in the patient's care planning for pressure ulcer prevention. So go home one more time. Remember, add up the numbers correctly, the lawyers do. The low score, 18 or below, the higher the patient is at risk of developing a pressure ulcer. So a low numerical score, let's say is a 7 or an 8, that your patient is at higher risk for developing pressure ulcer. Risk assessment scores are not perfect. There are some limitations to tools. No tool has perfect predictability, which means that there will be some patients at risk for developing a pressure ulcer that may not be identified by the tool. Even with a low subscale score, but a total Braden higher than 18, we need intervention, especially in that particular subscale. Since not all risk factors are contained on standardized risk assessment scales, relying only on a risk score for care planning could be identifying a person at risk for a pressure ulcer. And use a comprehensive approach to risk assessment to identify all patients' pressure ulcer risk factors. So don't just rely on numbers. Patients are more than numbers. So what do I mean by a comprehensive pressure ulcer risk assessment? That I've been using for many years to help teach people to look beyond the scales and some of the patient characteristics. For example, what is the patient's history? Have they had a pressure ulcer in the past? We know that when a patient has had a pressure ulcer, they are at higher risk for injury to tissue because the tensile strength of that tissue is never the same as unwounded skin. We need to assess comorbidities and medications for the patient. We need to look at the skin, see what it looks like, and we need to touch the skin, particularly looking at skin temperature. And we're going to talk just a little bit more about each of these areas. So it's not just about the sore. If you look at this heel on the right, the patient that came in, if you don't drill down and to the patient or their family, this heel's a little bit dry, but you may not know that this heel has chronic pressure ulcer, as you see on the left, 6 months previously. That's why you need to know the skin status, history of what has gone on with that skin as part of a comprehensive pressure ulcer risk assessment. So in the new NPUAP, EPUAP, PPPIA 2014 pressure ulcer guideline, at a B level of evidence, they say if they have an existing pressure ulcer, they ask for developing more, and certainly history of pressure ulcer, because tensile strength is only about 80%, they are at risk of developing pressure ulcers. We need to assess comorbidities and medications, and in the 2014 clinical guideline, and that full resource is at the end of this presentation on the slides. So if you want to look at it, and you can download the quick version for free from the NPUAP website, which is www.npp.org, and it is available in multiple languages besides English. It talks about the importance of assessing a patient's perfusion and oxygenation, as well as any nutritional deficits. But how do you assess this? This is not so easy, and we may need to look at measures such as the presence of certain comorbidities, including cardiac disease, peripheral vascular disease, respiratory status such as COPD, diabetes mellitus, these higher risk of pressure ulcers were actually found in a large study done by Courtney Leiter and colleagues, which was published in JAGS in 2014. They looked at over 51,000 patients that were 65 years and older, and this is what they found, the list that you see here, in terms of persons who developed pressure ulcers during hospitalization. So the reason why you look at comorbidities, corticosteroid use, again, impacts on the skin, and the skin becomes very thin, and thinner skin is not able to tolerate pressure as well as other aspects of skin. So, as I said in HOLD, L means you need to look at the skin, and again, Dr. Kowski does a whole webinar on that, so you can certainly look at more detail on that one. But take a look at bony prominences. The number one site for pressure ulcers is the sacrum. Number two is the heels. Certainly look at those areas. Take a look at our bariatric patients and wherever skin to skin is in contact. And there are interventions that you can do to prevent that contact. There are products that you can actually lay in between skin layers that have been found to reduce ulcers. Certainly, there has been a wide body of literature looking at prophylactic dressings on the sacrum and other body areas. And one study, for example, out of Australia, actually found patients that did not have a prophylactic dressings were 5.4 times more likely to develop a pressure ulcer than those who did not. And then finally, medical devices. Patients in hospitals have lots of different medical devices. This is one with a oxygen mask on here on the right-hand side. Certainly make sure that the medical device is the right size and fit and is applied correctly. In the new practice guidelines from the NPUAP, EPRP, PPPIA, they give very specific recommendations that the skin should be assessed at least twice daily, do more frequently if the patient has fluid shifts and or edema. They certainly say that if you don't need the device, take it off if the patient needs it. We talk about using prophylactic dressing underneath devices, but don't do it to excess. That is too much layering under the device and you cause pressure. And the last one is T in HOLD, and that is that you touch the skin and look at skin temperature. And there is some emerging evidence to suggest that skin temperature may predict pressure ulcer risk. So I want to refer you to work of Stephen Spriegel, and that full reference is at the back of the, as well from RAP, that looked at these temperatures may indicate pressure ulcer risk. Most of us are going to be assessing skin temperature by touching it, by using palpation. But more and more, some people are using non-contact infrared thermometers for temperature readings, even inexpensive little skin thermometers. And you can find them you can Google them on the web and find where they are. How about certain patient populations in care? So for our critically ill patients, for example, it may not be that they're receiving hypertensive medications to impact, or vasopressors to impact their hypotensive system, but the number of hypotensive episodes for those who are hemodynamically unstable. And that's the work of Hillary Shanks and her work that was published in the WCET journal. And also, of course, medical devices, which I've already talked about. Operative patients from the NPUAP guidelines, things such as the length of time somebody is in the hospital, in surgery, of hypotensive episodes during surgery, any low temperatures during surgery, and the amount of time that they're immobilized before and after surgery. One study by Chatham in 2001 actually found that pressure were reduced to zero when they used adequate padding for patients on the OR table. So take a look at patients that are in the prone position in the operating room and see if they have adequate padding. In one study that I was involved with at New York University, which has been published in JWOCN in 2011, with Delmore as the first author, to drop hospital-acquired pressure ulcer rates in surgical patients from 7.3% to 1.3% by putting an armband on the patient to alert them that their OR time had been greater than 4 hours and that they had been in a prone position, and that more frequent skin assessment was needed. So you take all these factors, which I've talked about as you see here, and there may be some that we don't know yet, and that's why the question mark is there. Skin assessment, medical devices, tissue oxygenation, standard scores such as the Braden scale, medications, co-morbidities, a history of pressure ulcers, current health, all of those factors you cipher down to make a decision. Is my patient at risk for a pressure ulcer? And you come up with a plan of care for the patient to hopefully prevent the ulcer. We use these risk assessment tools. It's going to be by staff that are trained quickly so that you can actually observe that people are using the scale correctly. That is in conjunction with a comprehensive skin assessment, overview of the patient, and clinical judgment, that you identify these risk factors so that you can begin to plan care that addresses each of these factors. And of course, they need to be consistent with patient preferences because patients have a choice and the care goals for that patient. So if you have an electronic health system in your hospital, you can integrate those assessment tools into the system. It makes it a lot easier for staff. So reliable tools such as the Norton Braden, train the staff how to use them properly. Sometimes I find that staff don't really go through. They just kind of eyeball the patient and write down numbers, or they copy forward the number so that the patient, as long as they're hospital, tends to have the exact same Braden score, even though their condition changes. So, you want to, again, make sure it really reflects what's going on with the patient. Associations on emissions and any change in their condition. And the reason you do this is you want to tailor your interventions based on the specific areas of risk that the patient has. As I said before, if the patient had a prior pressure ulcer, they're at risk of getting it again, particularly if there are similar circumstances such as the hemodynamically unstable. So you have a plan. Some steps in care planning, which is what we're going to talk about now that you've done the risk assessment, is you've identified person is at risk. You are going to select interventions to address those areas of risk that are consistent with the patient preference and care goals, and you need to communicate them, which means you have to write them down. You need to document them, and you need to share them with everybody who's involved with taking care of the patient. So make sure your staff does it correctly, does it consistently, and when you develop the plan of care, that they have access to the equipment and know how to use prevention equipment. One of the things that has been reported in the literature, actually a study by Shana, is that even though people did risk assessment and developed a plan of care, only 15% of patients had the preventative devices in place by day 3 after for them. So care planning for each category, as you see here, is in the resource section of the toolkit on page 138. So you can refer to that, and probably will be a lot easier to see than what I have here. But I'm going to break it down and talk about each of the areas in a little bit more detail later on when I give you some specific areas. I want to talk about some patient areas that you need to think about in terms of bariatric patients. That equipment that is available for staff to use for pressure ulcer prevention is the right size based on the patient's BMI and can support weight of the patient. So specifically with chairs, beds, codes, and toileting equipment, gowns, for example, that the patient is going to be needing because of their BMI, as well as that the staff is properly trained to use the equipment and have it available for patients. Now, remember that about 75% of patients get admitted through the ED in your particular hospital. So you want to remember that their pressure redistribution needs to happen in the ED also. So take a look at the stretchers and the gurneys that patients are on in the emergency room. We can't until they get up to the unit. And again, people are spending a little longer time sometimes in emergency rooms than they have in the past. For critically ill patients, we want to select pressure redistributing support surfaces that will enhance the patient's ability to have distribution of pressure, help with their perfusion and ability to be turned. And one of the problems with critical patients are people don't want to turn them because they're afraid that they're going to desat, that their perfusion isn't adequate, that the tubes are going to fall out. So NPOT guidelines actually talk about slow, gradual turns, motions, like little mini shift turns, allowing time for hemodynamic and oxygen stabilization to occur in the new guideline. And in the operating room, particularly patients in the prone position, there are facial pads that can be put around the patient's face. There should be appropriate pressure distribution cushions and padding on the operating room table. And don't get heel suspension devices so that patients' heels are not digging into the table. Population, particularly prone to pressure ulcers, is spinal cord injury patients. Spinal cord injury is in place. There's a loss of cortical bone and flattening of the tips of the ischial tuberosity. So make sure you assessing their skin that is offloaded while they're sitting in the wheelchair, for example. So for heels, you want to make sure that there's external rotation of the foot. So you want to use devices that will prevent plantar flexion. That means the foot extended, like bed linens, for example, and as well as pressure relief. Let's use a specific patient example to help you with your case here. So here's your hospitalized patient, and let's use the Braden scale. Here's what we've gleaned from our assessment of the patient. They can respond to verbal commands. They don't have any pain. They can turn and reposition with assistance, but need a couple of reminders. Encouragement to walk more than twice a day outside the room, but they are walking. Eat some of the food on his or her tray. Has not suffered any recent loss. And more dietitians are telling us that looking at weight pattern is a pretty good indicator of what might be going on nutritionally with patients. And this particular patient, the skin is moist because they have urinary and fecal incontinence. So what's the total risk score for this patient? And you can see on this next slide, I've actually circled based on those descriptors. So 4 for no impairment in sensory perception because they could respond to verbal commands and reporting no pain. Their skin was moist from urinary and fecal incontinence, so we picked a 2, very moist. Said the patient can walk, so and was walking outside the room at least twice daily, so gave them a 4. Slightly limited with mobility, that they needed to turn, but they needed some assistance. That nutrition, they would eat some of the food on the tray, and that we were worried about friction, not really worried too much about friction shear since this person was moving around. So let's break it down again. This was the form that's on page 138, where we broke it down by the different categories and the subscales of the Braden scale and tried to give you some suggested interventions based on some of the subscales that are there. So some of them are listed here. This is not all inclusive. So remember when you're assessing pain that there are various scales available. You can look at the John A. Hartford Institute. They're by this series. And if you need some help with pain assessment scales, remember that even a patient who is not verbal, such as somebody who is unconscious or somebody who has dementia, you can still be assessing pain for those patients. You certainly want to prevent and manage pain. So anytime you're lifting or transferring patients, use equipment. You want to give adequate pain medication and give it in enough time, particularly when you're going to be asking people to move around and you want them to be mobile. And sometimes pain medication is not the best way to deliver it. It may need to be delivered constantly to the patient. So here's a moisture subscale, here, for example. So we want to plan care for any of the moisture balance. So we do what the NPOAP guideline is referred to as preventative care. So you want to use products that are pH balanced. Remember, skin has an acid mantle, so we want to use products that are not going to destroy the acid mantle and make the skin alkaline, because once it's alkaline, bacteria can grow on it, for example, and we don't want that to happen. So massaging or vigorously rubbing skin, you don't want to be creating friction injuries, and anytime you destroy the epidermis of the skin, you make it more vulnerable to pressure injury. You also want to take care of dry skin, so you want to use moisturizing products such as lotions and creams, and these are best applied, by the way, when it is still a little bit damp from the cleaning process. And a variety of products out there. Make sure your staff has access to them. Locking them up doesn't help them to get them to use them, and too much of a good thing is not good either. Or you should have a formulary so that you have decide what lotion, creams, skin products you have available for your staff to use. And one institution, they actually have labeled them on a skincare card so that people know what to use when for patients. So that's a strategy for people to do. That's too moisture so to get skin damage, which can from incontinence or perspiration. You want to obviously clean the skin as promptly as possible after the episode of the incontinence or the moisture episode. And once again, you're going to use skin products such as lotions, creams, and some of the skin sealant products that can either pad or on a stick form. Remember, if the skin is denuded in any way and is open, you want to avoid any products that have alcohol and could cause increased pain or stinging to skin. In terms of activity problems, so the person is sitting in a wheelchair, you want to make sure that the wheelchair is the proper size for the patient. And there are lots of articles out there that talk about how to do that. But at least for the referral to PT and OT is best here because they're experts in the correct sizing of wheelchairs. And is there a support cushion to redistribute pressure in the wheelchair? Remember, we all have a life expectancy, and so do support cushions. So a cushion that's been there for a very long time probably is not providing pressure redistribution. So you need to evaluate whether it is still really performing a function of redistributing the pressure or not. Mobility problems, again, you want to keep heels off the mattresses. The literature really does not support the use of pillows for long-term pressure redistribution. And if you do, you want to make sure that you don't injure the Achilles tendon, so make sure that you are positioning the pills correctly if that's the only device you have available to them. But there are heel suspension devices that are clinically available. There is a cost to them, of course, but you really make sure that the heels are suspended in the device, but make sure you know how your staff knows how to put them on correctly, because you cause a pressure ulcer, and that you are check the skin. Unfortunately, there are lawsuits when people don't remove suspension devices or in TED stockings and check the skin of patients. TED stockings or anti-embolite stockings are not pressure ulcer devices, but again, another medical device that you need to be assessing the skin for immobile patients. In our nutrition, you certainly encourage, if the patient is able to eat, to bring in their favorite foods. Make sure you offer enough water. Remember, we are basically water beings, so we need to have lots of water in our bodies, and that if the patient needs supplements, make sure they're actually taking the supplements, that they're not just piling up on the bedside stand. And then looking at weight patterns to see how stable somebody's weight is a good marker for the success of your prevention and intervention plans. And then friction and shear. Again, there's a large body of knowledge that has been in terms of looking at polyurethane foam dressings, and there have been studies in. First study actually was done in Japan, and there are several here in the United States in critical care areas, and one in South Korea that have really looked at using these polyethylene foam dressings. Exactly how they work is not truly understood at this particular time in terms of prevention. The leading theory is that it has to do with the microclimate aspect of pressure development, and that would be why there is success. But again, over-reliance on any intervention is not. We need training and repositioning patients. We need to be assessing the skin. Don't just think because I'm doing something I don't have to do by these other factors. And then in the new NPUAP, EPP, PPPIA 2014 guidelines, they talk about fabrics using silk-like fabrics rather than cotton or cotton fabrics on bedding, for example, that they have a role in of emerging therapies for pressure ulcer prevention. Today, I've talked a lot about pressure ulcer risk assessment factors. I've talked about how to do a risk assessment. I've talked in detail about how to use the Braden scale. And finally concluded, and I'd like to bring it all home to the reality that if you do a risk assessment but don't do it plan care, it's not going to help the patient. And once again, best served player will not prevent a pressure ulcer if you don't implement strategies consistently and use them with the patients. And again, monitor that everybody who's taking care of the patient understands what needs to be done and is really doing it. And with that, I want to thank you for being such great listeners. And once again, those questions that you wrote down during the presentation, that you bring them to your QI specialist. Thank you and have a great day.